Welcome to this educational module on the Pecto-Intercostal Fascial Plane Block, or PIFB. This presentation was developed as part of a Doctor of Nursing Practice project at the University of Southern Mississippi. During this module, we'll review the indications for the PIFB, the relevant anatomy, ultrasound landmarks, procedural technique, and important safety considerations. By the end of this presentation, you should understand the fundamental knowledge required to safely perform this regional anesthesia techniques. The Pecto-Intercostal Fascial Plane Block is an ultrasound-guided regional anesthesia technique, commonly used as part of a multimodal analgesic strategy for patients undergoing median stenotomy, especially during coronary artery bypass graft surgery. The goal of the block is to anesthetize the anterior cutaneous branches of the thoracic intercostal nerves from T2 through T6. Local anesthetic is deposited within the fascial plane between the pectoralis major muscle and the internal intercostal muscle. This provides analgesia to the sternum and parasternal chest wall, while preserving motor function. Typical injection volumes range from 10 to 20 milliliters per side. Absolute contraindications include patient refusal and significant coagulopathy. Numerous studies have demonstrated the clinical effectiveness of the Pecto-Intercostal Fascial Plane Block. Patients receiving this block consistently report lower postoperative pain scores, reduced opioid consumption, and improved comfort during coughing, deep breathing, and early mobilization. These findings support incorporating the PIFB into Enhanced Recovery After Surgery, or ERAS, pathways for cardiac surgery patients. Before performing the block, gather all required equipment. Standard OSCE monitors should be applied. A high-frequency linear ultrasound probe is preferred, with the imaging depth typically set between 2 and 3 centimeters. Maintain strict sterile technique by using sterile gloves, a probe cover, sterile ultrasound gel, and chlorhexidine or povidone iodine skin preparation. A 50 to 80 mm, 21-gauge regional anesthesia needle is commonly used. Prepare a syringe containing 10 to 20 milliliters of local anesthetic, such as bupivacaine or ropivacaine, while remaining within the maximum recommended weight-based dose. From superficial to deep, you'll see skin, subcutaneous tissue, pectoralis major, the intercostal muscle layer, transversus thoracis, and pleura. The target is the fascial plane beneath the pectoralis major, above the intercostal layer. Near the sternum, the intercostal nerves, T2 to T6, pierce the muscle layers and become anterior cutaneous branches, supplying the parasternal skin. PIFB superficially targets these nerves before they exit. Let's briefly discuss what this block actually provides. The PIFB is a sensory block. It anesthetizes the anterior cutaneous branches of the thoracic intercostal nerves from T2 through T6. Because motor nerves are not affected, patients maintain normal chest wall movement, making this an excellent option for preoperative and postoperative analgesia. Position the patient supine, palpate the sternum, then identify the third and fourth ribs, or corresponding intercostal spaces. Next, position the ultrasound probe. Place the linear probe in a parasagittal orientation, approximately 2 to 3 centimeters lateral to the sternum, over the third or fourth intercostal space. Minor adjustments in probe pressure, tilt, or rotation may be required to obtain optimal visualization of the tissue layers and the rib shadows. Now identify the important anatomy. Note: the acoustic shadow created by the ribs helps orient the anatomy. From superficial to deep, locate the pectoralis major muscle, the internal intercostal muscle, the internal thoracic artery, also known as the mammary artery, and finally the pleura or lung. The target for this regional block is the fascial plane below, or deep, to the pectoralis major, and above, or superior, to the internal intercostal muscle. A quick clinical pearl before inserting the needle. Activate color Doppler to further identify and avoid the internal thoracic artery or mammary artery, reducing the risk of vascular puncture to this structure. This is especially important for coronary artery bypass graft surgeries, where the mammary artery is commonly harvested and used as a bypass graft conduit. Once the anatomy is identified, you're ready for needle insertion. Advance the needle with an in-plane ultrasound approach from caudal to cranial, approximately 10 to 30 degrees, keeping the needle just superior to the rib. Continuously visualize the needle tip as it advances toward the fascial plane between the pectoralis major muscle and the underlying intercostal muscle. Maintaining continuous needle visualization is essential for procedural safety. The target injection site is the fascial plane immediately deep to the pectoralis major muscle and superficial to the internal intercostal muscle. When local anesthetic is deposited within this plane, It spreads longitudinally to surround the anterior cutaneous branches of the thoracic intercostal nerves. Accurate placement within this fascial plane is the key to successful analgesia. Before injecting, always aspirate. As to not inject intravascular, inject 1 to 2 milliliters of local anesthetic first, to confirm correct placement with hydrodissection. This confirms correct placement by visibly separating the fascial plane under ultrasound. Once the fascial plane opens, slowly inject the remaining local anesthetic, while observing the spread throughout the plane, and repeat the procedure on the opposite side to achieve bilateral sternotomy analgesia. Let's quickly review the steps of the Pecto-Intercostal Fascial Plane Block, or PIFB. First, position the patient supine with the anterior chest fully exposed. Next, place the ultrasound probe approximately 2 to 3 centimeters lateral to the sternum over the 3rd to 4th ribs. Under ultrasound guidance, identify the key anatomical structures. Visualize the pectoralis major muscle, the fascial plane, the internal intercostal muscle, the internal thoracic or mammary artery, and the pleura. Remember, the target is the fascial plane between the pectoralis major and the internal intercostal muscle. Insert the block needle in plane, advancing carefully into the target fascial plane. Once the needle tip is in position, perform negative aspiration to help rule out inadvertent intravascular placement. Next, inject 1 to 2 milliliters of local anesthetic to produce hydrodissection. This confirms that the needle tip is correctly positioned within the fascial plane. Once proper spread is visualized, inject the remaining local anesthetic for a total volume of approximately 10 to 20 milliliters. Finally, repeat the same procedure on the contralateral side to provide bilateral analgesia for median sternotomy. Please watch this quick animation of needle insertion and needle pathway as it travels to the target fascial plane. Notice the fascial plane beneath the pectoralis major muscle, the location of the internal thoracic artery, and the pleura beneath. Watch the spread of the local anesthetic in the pecto-intercostal fascial plane. Now let's watch the block under ultrasound guidance. Observe the needle tip advancing beneath the pectoralis major muscle while remaining superficial to the pleura. Notice the hydrodissection created by the initial injection and the spread of local anesthetic within the pecto-intercostal fascial plane. This spread along the fascial plane indicated a successful pecto-intercostal fascial plane block. Although this is considered a safe procedure, complications can occur. Potential risks include pneumothorax, vascular puncture, bleeding, infection, and local anesthetic systemic toxicity, also known as LAST. Careful ultrasound guidance, continuous needle visualization, and frequent aspiration help minimize these risks. Congratulations! You've completed this educational module. You should now understand the indications, anatomy, ultrasound landmarks, and procedural steps for performing the pecto-intercostal fascial plane block. Please continue back to the Qualtrics website for a viewing of the Pecto-Intercostal Fascial Plane Block OSCE document. After you have viewed the PIFB OSCE document, you will be directed to the Post-Education Module survey. Please complete the survey to the best of your ability. Thank you for your participation in the Pecto-Intercostal Fascial Plane Block OSCE research project.